There's a class of drugs that are associated with the Alzheimer's condition itself.
Yes, so this is so exciting to me.
I love that you're getting excited about this, by the way.
We were sitting on the porch in the back of our tent when a lion walked through below the porch.
How did you feel in that moment?
Uncertain.
Dr. Jeffrey Cummings, thank you so much for being here. We're going to talk about a lot of different things. One of them is your background, but we're going to start off actually jumping straight into your area of specialization. You're world-renowned in Alzheimer's disease. We're going to talk about a statement that you actually made several years ago, and then we're going to wind it back and talk about how you got involved in neurodegenerative diseases, the brain, and Alzheimer's disease. So I'm going to read a quote to you, your quote, from 13 years ago. So if we don't solve the Alzheimer's disease problem, we're going to be overwhelmed. So talk to me a little bit about that, where that quote came from, and really what's happened over the last 13 years to try to solve the problem.
First of all, Mark, thank you very much for having me on the program. Really great to be here. I feel honored to be here. And that quote is still absolutely true. The world is aging. Globally, the age of the population is increasing. In the U.S., the age of the population is increasing, and Alzheimer's disease is an age-related disorder. So it becomes more common in the population every year, not because it's spreading in the population, but because the population has more and more older people who are subject to Alzheimer's disease. And it is a very expensive disease, both from a human point of view and from an economic point of view. So if we do not find ways to delay or prevent or more effectively treat Alzheimer's disease, the cost and the human cost will be very, very high.
Yeah, I think the human cost is something that people who have experienced anyone with Alzheimer's understands that, but outside of that, someone who hasn't experienced it as a caregiver, for example, may not understand entirely the cost. That's going to be more and more rare, right? People who have not experienced Alzheimer's in their family as we go forward. But can you talk a little bit more about that? What the personal cost is for people?
Well, they say that every patient has at least 4 people who are providing care for them. So with that kind of geometry, there's almost no one who has not experienced Alzheimer's disease in their family or their extended family. And it is such a demanding experience that this person increasingly depends on you. And it starts off just a little bit of word finding, helping me find the word in the sentence. And then, of course, it becomes helping me with my memory, and then it becomes helping me with my dressing, and then it becomes helping me with my walking. And so it is a progressive loss of autonomy for the individual and a progressive dependence on the caregiver for the person who's providing that care.
You've just explained that so simply and so beautifully, and yet you are a world expert on Alzheimer's disease. So just for the sake of the audience and for all of us, let's talk about who you are, because it's really fascinating, and I think it's not just some person that's saying this. This is a world expert. So you're a distinguished professor at UNLV, have been for several years. You were formerly at the Ruvo Center, which we'll talk about briefly. And then, we talked about this a little bit. You've got so many awards, very deserved awards over the years. If you wouldn't mind, tell us one that or a couple that you're very proud of and why you're proud of that particular award.
Thank you for this great question. Yeah. I love to talk about my awards, of course. The one that's most meaningful to me is called the Bent Winblatt Lifetime Achievement Award. It is awarded by the National Alzheimer's Association after a very, very thorough consideration of candidates who have spent a lifetime trying to solve the issues of Alzheimer's disease. So it's a great honor to get such an award. And it's special for me because I know Ben Winblatt. He's a living scientist who has been very influential in Alzheimer's disease. He's Swedish. He was the leader of Swedish Alzheimer's disease research and of European Alzheimer's disease research. I value him as a precious friend, and the fact that I have an award that bears his name makes it particularly meaningful to me.
Yeah, that's wonderful. And, you know, you've got the Bent Altblatt, and now let's go all the way back. You're a young man growing up in Wyoming. Can you take us through that journey, the journey of your life from here to Bent Altblatt?
Yes, well, I value my life in Wyoming. I was born in a small town in northern Wyoming called Basin, and went to college at the University of Wyoming, and while there, decided that medicine would be a good future for me. My father had not finished high school, so there wasn't a president in our family. My mother had high school plus one additional year that allowed her to teach normal school during the war in a small country school. So that was my family background, and no one had gone to college from my immediate family. But I was fascinated by first college and then medicine, and was fortunate enough to be able to get scholarships and find support to allow me to go to medical school at the University of Washington in Seattle. Then I studied neurology at Boston University in Boston and at the Queen Square National Hospital for Nervous Diseases in London, and then found my way to direct the Alzheimer's Disease Center in Los Angeles. And that was before I came, as you mentioned, to the Lou Ruvo Center here in Las Vegas.
So one of the stops along that journey was Queen Square. Can you talk a little bit about how you got there and why?
Yes. So I'm a neurologist, and there has been a tradition in neurology of Queen Square going to essentially the mother church of neurology, because so many great neurologists led the programs at Queen Square. Lord Brain, Henry Head. Those are the names that
These are real names.
That turned.
Lord
Those
Brain.
are real
Yeah.
names, and you must be a neurologist if those are your names.
Yeah.
So there were just many leading neurologists, and so I felt like I wanted to follow the tradition, and it was great. I went. They were very supportive of me. I studied a disease called Pick's disease and wrote some initial papers around Pick's disease. We absolutely enjoyed the time in London, and being able to get out of one medical system to look at a different medical system enriches your ability to understand the systems to come. And I really have valued that experience.
What is Pick's disease?
Pick's disease is a disease of the brain, progressive, something like Alzheimer's disease, but it affects the frontal part of the brain rather than the language and memory parts of the brain like Alzheimer's. So the person becomes more socially disabled. Our frontal lobes give us social restraint to allow us to have more normal social interactions, and those restraints are lost in patients with Pick's disease. And it has a unique pathology, which I studied while I was there, and is still a subject of great interest in the neurological community.
It's so Phineas Gage comes to mind when you're talking about that. Can you talk a little bit about him?
Yes, so Phineas Gage, of course, is a very famous case of a person in New England working on the railroad, and he was tamping blasting powder into the ground, and the blasting powder exploded and blew the tamping iron through his brain, specifically through the frontal part of his brain. And the doctors who attended to him when he recovered said, "Gage is Gage no more." It was because his personality was so dramatically changed by this loss of inhibition that the frontal lobe provides. And patients with Pick's disease have this same kind of loss of inhibition.
So several years ago, I worked for a short time at Wash U in St. Louis, and we had an Alzheimer's patient that came in that had frontal, a dementia patient that had frontal dementia. Older woman who apparently was very, very nice prior to the condition, and she had lost all impulse control. I'm sure you've dealt with people like that before. And
yes, I have. One of my experiences, I had a woman with frontal lobe dementia, and I had her sitting on my examination table, and I was doing her knee reflexes, as neurologists will. And she leaned over and messed up my hair and said, "You're so cute, doctor." And that's a distinctly unusual interaction.
So let's go back a little bit. I want to ask you, you made an interesting statement about how the American medical institution, educational institution, and European, England in this case, they're different.
Yes, they are.
Talk a little bit about that, please.
One of the things that struck me most was the very hierarchical expectations in the British system. So we would go to rounds, and there were chairs in the room where we would sit to interview patients. And there were a couple of very nice padded chairs, and then there were some very hard straight back chairs. And Americans would inevitably come in and sit in the nice padded chairs,
Yeah.
at which point they would be redirected to the hard chairs, because those chairs were for the registrars that were more advanced in training, and they were the British registrars. So it was just interesting to see the hierarchical expectations in the British system.
So did you sit in the hard chairs or the soft chairs?
I sat in the hard chairs for 6 months.
That's great. So let's continue down. You know, we started this by you talking about the potential of Alzheimer's to overwhelm us as a culture, and us being the U.S., but it's most of the world. So it's not unique to folks in the U.S. Let's take a step back and just talk about what is Alzheimer's, what's the history of it, the biology of it, and so forth.
So let me just pick up on the point you made about this being a global problem. It's projected that by 2050, 60% of all Alzheimer patients will live in China.
Wow.
Because the growth of the Chinese population and the aging of the population is such that they will have more dementia patients than any other country in the world.
Okay, I just want to make sure I heard this correctly. 60% of all Alzheimer's patients
will live in China.
Will live in China.
Because our population, although it is aging much more slowly than the Chinese population. And the Chinese population, of course, is already much larger than our population. Mm-hmm. So when you put those forces together, then you see that the number of Alzheimer patients in China and in the low and middle income countries more generally will be very high compared to Western countries.
Why is that?
Because of they are now having the public health successes that allow people to live into advanced ages. Mm. And of course, that's great on one hand, but it allows people to live into the dementia risk years more regularly. And therefore, there's a disproportionate increase in those countries that are just now enjoying aging as part of their population growth.
So with that enormous number of individuals in China who will have Alzheimer's disease, is the country doing anything in particular? Like, are they at the forefront of the science of Alzheimer's?
I wouldn't say they're at the forefront, but I would say, for example, that Japan has been very forward-looking, and they already have quite an aged population compared to other world populations. So in terms of public health measures and measures to assist older individuals who may be partially or more seriously compromised, Japan has a lot for us to learn. And we've been paying attention to those lessons. Now, the major science is still coming from the United States, and that's where the great advances have been in terms of the science of Alzheimer's disease is from advances in the United States.
Yeah, well, and we're going to talk about that because that's really an area of specialization for you. Let's go back a little bit and talk about what is Alzheimer's.
Yeah, so Alzheimer's disease is a progressive disease that occurs in older individuals, and it results from the death of nerve cells. And the nerve cells are dying because two toxic proteins accumulate in the brain. And in those individuals who are unable to clear that protein from the brain, the protein accumulates, it accumulates to a level where it kills the nerve cells. And this tendency to accumulate the protein occurs more and more as we age. And that's why this is a disorder of older people.
So, at one point, you're talking about plaques and tangles.
Yes, I am.
And at one point, there were correlational studies, right? They would find individuals that had more plaques, for example, in the brain are more likely to have Alzheimer's. Have they moved into the idea of this being causal?
I think yes. There's still a lot of controversy in the field, for sure, and so not everyone would agree with what I'm going to say. But I think a consensus is that at least the earliest detectable change is in the accumulation of amyloid, and when amyloid accumulates, there's then an explosion of the tau protein. The tau protein is there at very low levels in almost everyone. And then when the amyloid accumulates, the catastrophe occurs. And the catastrophe leads to inflammation in the brain and cell death. So it appears to be that there's a kind of sequence of amyloid followed by tau, followed by cell death. And the amyloid itself can be in the brain quite a long time, maybe 10 or 15 years before some threshold is crossed that the catastrophe occurs. And then the rest of the disease is set in motion.
So if that's the case, then one of the early ways to detect the future incidence of Alzheimer's would be being able to see the amyloid. Correct?
That's absolutely right. And how do we know this? How do we know that the amyloid is in the brain for 15 years if it doesn't have symptoms? It's because, exactly as you say, we now have these fantastic scans where we do an injection of a substance that will cling only to the amyloid plaques. So if the scan is positive, it's because there are plaques in the brain. And if there are no plaques, it will be a negative scan. So it's really quite a remarkable advance, and it is that kind of biomarker, a biological measure, that has allowed us to forge ahead with new drugs in a way we've never been able to do before.
Yeah, so I want to talk about this a lot more because it's a fascinating topic. Let's get a little bit more into the biology of the disease. So particular areas of the brain you had mentioned before, memory centers and so forth. Can you talk a bit about that?
Yes, the memory is formed in the inside part of the temporal lobe. There are 4 lobes in the brain: temporal, frontal, parietal, and occipital, and it is the temporal part of the brain that on which memory depends. And that is the very first area that is struck by Alzheimer's disease. So it's why the very first sign of Alzheimer's disease is repeating the same question, because you give the answer, but the person doesn't record the answer. So the question is new to them when they restate it to you. And that repeated questioning is such a hallmark of early Alzheimer's disease, and it is the signature that the temporal lobe is involved.
And at this point, we're talking about, like in an assessment that you would do with an individual, we all have some forgetting, right? And especially as we get older. Where does the line differentiate between normal forgetting and someone who may have some form of dementia?
This can be difficult, but in general, the person who has Alzheimer's disease does not record the information. So I give them 5 words to remember, and then later I ask them those 5 words, and they don't remember. But I also give them clues, and the clues don't help because the information isn't there. So the clues cannot help. Whereas in a person who's forgetful for other reasons, the clues are almost always helpful.
Oh, yeah.
So the response to the cluing is a very important observation in the person who knows how to do this examination.
Because the person without Alzheimer's, the clues provide them, the clues provide them some additional information so that they can recover the information, right? Maybe a recall issue, not a memory issue.
That's exactly right. They are storing the information, but they can't access it in a timely way, the way they want. But they will respond almost immediately to the clues. You've had this experience. You see someone you know very well. You have 2 steps to be able to recall their name before you shake their hand. And you have to say, "Great to see you, friend," because their name doesn't come to mind. And then a minute later, it's Bill, and then you build it into that sentence to come because it's there. The name is there. What you need is a little time or a hint to get to it. But the Alzheimer's disease patient doesn't have the information stored, and therefore those hints and clues do not work.
Yeah, it's really interesting because the encoding of information, the decoding of information, right? Taking it in and then using it. So some of us have a trouble with the decoding, right? Remembering it, but we could do it with clues. What you're saying is that Alzheimer's have a problem with encoding, or actually storing the information in the first place.
That's exactly right. And because it's the new encoding which is affected, it is their newest memories which are most affected. So in Alzheimer's disease, memory is erased from the most recent to the most remote. And so you can interview a patient and say, well, how are you doing? And they might say, I'm doing really well. I have a new car. And that new car might now be 10 years old. But that's the point to which their memory has been erased.
Okay, so we don't have a script, but I'm going to go off script on this one. The movie The Notebook, right? So the person every now and then will just come back and she'll be perfectly fine from a memory. She'll remember everything and so forth. I have this debate with people all the time. How realistic is that movie?
Almost all caregivers have had experiences where people for short periods of time will be able to recall some event, particularly an event. It's not like they're storing new memories, but they'll recall an event very well. And this usually occurs under periods of stress, oddly. And my hypothesis is because you must respond, you have a hormonal response, and all of a sudden it comes together for you. But it's short. It's a window of time, and so those periods of lucidity are brief and increasingly fleeting over the course of the illness. But they do occur, and they occur under these very peculiar circumstances.
So some of the notebook might be somewhat realistic. If you don't mind, we'll keep this to ourselves because I would lose an argument. Several of them, actually. A few years ago, I was working with a group out at Sun City and talking with their executive team. And it's a older adult community, as you know. And a woman came in very distressed. Older woman came in very distressed. You reminded me about when you said the car. She had misplaced her car, and in fact, she felt that it was stolen. And so she came in. She said, "My car was stolen. I parked it right here." We walked out. I walked out to the parking lot with her. Sure enough, there was an empty stall where she said her car was, and so forth and so on. And I went in to interrupt the executive team and said, "Could I get your help? This this lady's car has been stolen. And they knew her and said, yeah, this happens every week or so that she believes, but she hasn't actually driven for 20 years. And it's interesting because she had such a clear memory of her car being parked in that place. And it's sad. It goes back to what you said, right? The human cost of this.
That's right. And those kind of delusional beliefs that are superimposed, it's not only that she had the belief her car was there, it's also the belief that it was stolen. So that's sort of the next level of interpretation, that I'm the victim of malicious behavior here. Fortunately, we are evolving drugs that can treat the psychotic elements of Alzheimer's disease, in addition to evolving drugs that are treating the disease itself. So there are two fronts of progress in terms of therapeutic development.
So this is a great segue. Can you talk about the two different areas that you just mentioned, the psychotic and the disease itself?
Yes. So one of the major behavioral problems of Alzheimer's disease, the major behavioral problem, is agitation. And just this last year, a drug was approved by the FDA for the treatment of agitation in Alzheimer's disease. It is the first drug for any neuropsychiatric syndrome in Alzheimer's disease, and almost the first drug for any neuropsychiatric syndrome in any neurological disease. So we've been very slow to make progress here, and this particular drug, brexpiprazole, had 3 positive trials showing that it effectively reduced agitation in patients with Alzheimer's type of dementia.
And can you say the name again?
Brexpiprazole.
And is it currently a prescribed medication?
Yes, it is.
Okay.
It was previously approved for treatment of major depression and for childhood schizophrenia. And then the companies decided it was a candidate to be tested for agitation in Alzheimer's disease, and it was successful in that program.
So is the same medication used for other areas of dementia as well? And sorry, let me be more specific. Let's first talk about the different types of dementia. And then the question is the same medication used for agitation in those different types of dementia?
So there are several types of dementia, and maybe we should start, Mark, by making a distinction between dementia and Alzheimer's disease. So dementia is a generic term. It means a person is sufficiently cognitively compromised that their function is also compromised, their daily function. So there are many, many causes of that syndrome, of which Alzheimer's is the most common. But there are a lot of other disorders that will produce a dementia syndrome. We've talked about Pick's disease and frontal dementia. There's vascular dementia, which is quite common. There's a disorder called dementia with Lewy bodies, which is kind of the marriage of Alzheimer's and Parkinson's disease. So there are other major causes of dementia. Now, this drug would be a candidate for treatment of agitation in those disorders, but it's not approved. So it would be on label for use in Alzheimer's disease, and it would be off-label if one used it in one of the other disorders. But you're forced to make these decisions as a doctor because there are no approved drugs. So you would choose a drug that at least had a history of approval in Alzheimer's disease if you were going to use such a drug in another dementia syndrome.
And so the drug that we're talking about now would take care of some of the issues, not the disease per se, but some of the side effects, if you will, of the disease of Alzheimer's.
That's exactly right. It's very distressing to have someone who is shouting and kicking, and it's one of the most common reasons for nursing home admission. So the idea that we now have an intervention for agitation is a tremendous sign of progress in Alzheimer's disease.
Well, to your point, I mean, I think that people who haven't experienced individuals with Alzheimer's may not know how distressing this is. But yeah, we keep coming back to the human cost.
That's right. Yeah, and agitation is a good example of the human cost, where where the pressures on the spouse are so great if the person doesn't recognize them to be the spouse, or believes that they're having an affair, or believes that they're stealing something from them, and then gets really angry about it and shouts. These are intolerable circumstances for usually an older spouse to accept.
Yeah, and I think along with that, caregivers in general are often the person that the Alzheimer's patient will strike out at most, partly because they're around most often, but that it's just very difficult for that individual.
I think that's right, Mark. There's a kind of permission to be yourself with someone you love. And therefore, I think the Alzheimer patient feels more liberated to express their distress when they're around a caregiver. But of course, that's very destructive to the caregiver.
Right. So you also said there's a class of drugs that are associated with the Alzheimer's condition itself.
Yes, so this is so exciting to me. There was a period from 2004
I love that you're getting excited about this, by the way.
to 2021 where there were no new Alzheimer's disease drugs approved. 17
Wow.
years, $44.4 billion worth of pharmaceutical investment.
Wow.
And with no drugs. And then in 2021, it was decided that antibodies that are known to remove foreign substances from the body might be directed at amyloid. And if the cells could be directed to amyloid and they removed it, would that help? So antibodies were raised in the laboratory and infused into patients, and those antibodies then activated the cells of the brain to remove the amyloid. They did so dramatically. They reduced the amyloid to undetectable levels given our current technologies, and they slowed the progress of the disease about 30%.
Oh, wow.
So there's an argument about, well, is that enough? But I think for the first drug, for the first breakthrough, for the first time that we can actually change the biology of the disease, I think 30% is remarkable. And of course, we wanted to get it to 50 and 70 and then eventually arrest the progression of the disease. But it's a solid benchmark to start. There was a lot of controversy about this drug, but it has since been seen almost exactly the same with two more drugs. So it's there, it's established. Two of those drugs are now approved. One of the drugs is under review right now by the FDA. So these drugs change the disease, and they extend the period in which one has relatively good function. So if I'm in the mild cognitive impairment phase of my disease, where I have some memory impairment, but I can still do most things for myself. If that period were 3 years without treatment, it would now be 4 years before I would progress into dementia, the more severe part of the illness. Well, that year is critical in a person who is only going to live about 10 more years. So for me, this has been just a remarkable change in the field.
So one of the things that strikes me as you say this is it's decreased amyloid to an undetectable level. We know amyloid is related to Alzheimer's disease. So if amyloid is completely gone, why wouldn't the disease be gone?
Really great question. And what we can see with new biomarkers, new blood tests for Alzheimer's disease, which has been another part of the remarkable story that's going on. But we can see that tau is going down as well, and that an indicator of brain inflammation is going down. So we see that the removal of the amyloid does have a lot of downstream effects. But removing the plaques, which is the visible part on the scan, may not be changing all of the underlying biology. And we think that's why it's continuing to progress and why we still need other drugs. Like maybe we need a tau drug. Maybe we need an Alzheimer and a tau drug, or maybe an amyloid and a tau drug, or maybe we need an amyloid and an inflammation drug that would be given simultaneously. But now we can build on the foundation of knowing that the amyloid drugs are successful to go to that next level.
So it might be that the amyloid drug is, because you're decreasing amyloid, you're decreasing the progression of the disease, but there is already damage done.
That's right. There's already very substantial damage done even though these patients are early. At that time of intervention, there's still just enormous number of changes in the brain.
So our best hope at this point is to slow the progression of the disease rather than actually stop the disease.
I think another great hope is to prevent the disease.
Yeah.
And there are currently 2 phase 3 trials, so very advanced trials, of the same class of drugs where you would prevent the progression of the disease and the emergence of symptoms. So prevention is a feasible outcome of our current drugs.
So if that's the case, for example, and I find that I've got early symptoms of Alzheimer's and I start taking this drug, it won't reverse that, but it would stop that if all goes well.
Yeah, that's exactly right. And we might be able to stop it before you had any symptoms.
Well,
and the drugs, although they're now given intravenously, we have already on the horizon subcutaneous drugs. And although we currently need a scan to make the diagnosis, we already have in hand a blood test that we have increasing confidence in to make the diagnosis. So with a subcutaneous injection and identifying people with a blood test, we can help millions of individuals.
Wow, that's just amazing. That is amazing. Yeah, you've got to be proud of the work that you've been doing. I know that there's a lot of people doing this work, but you're definitely at the forefront.
Well, it's taken a long time, and it's taken a lot of people, and I am enormously pleased to be part of it.
Yeah. So this is just fascinating to me that we're making these, 2 parts. One, that we went 17 years without making any movement, and now all of a sudden we've I shouldn't say we, you have made tremendous movement. So, and 5 years from now?
5 years from now, I think, one, we'll have the subcutaneous injections.
Mm-hmm.
People will be able to do it at home. We'll have a blood test that we're confident in. And we will have various types of combinations in play. You know that medicine is moving towards precision medicine, that each individual is truly an individual. So how individualized can our therapies be? And I think between the combination of the blood test, this person has high inflammation, they need an anti-inflammatory with their amyloid drug. This person has high tau in the blood, this person needs a tau drug with their amyloid drug. So I think increasingly we're going to be able to sculpt the choices that the doctor has through a combination of very revealing blood tests and a corresponding therapeutic intervention.
That's incredibly exciting as well. And how would you guess that artificial intelligence, AI, would overlap with this as well?
We're seeing AI in every aspect of drug development now. I'll just give you a couple of examples. There's a lot of information from studying proteins in the brain and in the blood, but there are thousands of them. So the human intellect has difficulty understanding the patterns that are there among thousands of proteins. But with AI, the protein repertoire can be dissected into pathways. And then you say, here's an inflammatory pathway. Here's a tau pathway. Here is an oxidation pathway. And that's how we're going to get to this precision medicine. Another use of AI, which I love, is one of the greatest problems of Alzheimer's therapeutics is getting enough people into trials fast enough. So now AI is being used to search the medical record, the electronic medical record, to discover patterns of people who would be appropriate to invite into a clinical trial. And those are just two examples. AI is being used for more practical things like protocol construction and even workforce deployment in drug development. But some of the most exciting are, well, let's figure out the biology, and then let's figure out how to accelerate the trials.
So, clinical trials, you've mentioned this several times along the way. Let's go into some detail about what are clinical trials and how do they work? And then you just said about how AI is going to have a role in this as well.
The only type of evidence that the FDA will accept to approve a drug comes from a placebo-controlled trial. Our belief structure is such that if there's no placebo, everybody responds to the therapy, at least transiently. Of course, they're not going to respond throughout the whole course of Alzheimer's disease, but they will respond enough to confuse our understanding of the drug effect. So we have to have placebos. So in the early part of drug development, the drugs are tested in animals. And the animals are usually not sacrificed. It's just to see whether they get whether there's any cardiac toxicity or liver toxicity in the animal, and then we'll know whether to anticipate that in humans. In phase 1, we start off with normal volunteers and understand how the drug is handled by a normal volunteer. In phase 2, then, that we go to Alzheimer's disease to see, does the drug affect Alzheimer's disease? If it looks like it does, then it would be progressed to phase 3, which is the final step before a drug goes to the FDA. And it's important to emphasize that the Alzheimer's disease field has a 99% failure rate for drug development. So most drugs fail. And it's only the occasional drug, like these immunotherapies that we're talking about, that are powerful enough that they have an effect which is routinely detectable in clinical trials and therefore can be approved by the FDA.
Why is the failure rate so high?
Because we have not understood the biology well enough, and until recently we've not had the biomarkers. So essentially, we were shooting in the dark, and now we have a shot on goal. And that shot on goal is defined by the biomarker. Because if we're not affecting the biomarker, we have no chance of affecting cognition in that patient, and we should stop the drug now and get on to the next project.
So theoretically, the success rate of drugs is going to go up dramatically with the biomarkers.
I think we're standing right on the edge of a total change in Alzheimer's disease drug development.
That's exciting. That's very exciting. Yeah. And so what are you working on right now?
Well, my passion is to understand how drugs are developed. What are the things that make drug development more successful? When I say things, I mean like biomarkers, like memory measures that might be used, even like what patients are best to study in terms of a clinical trial. So we follow all drugs that are registered on clinicaltrials.gov, which is mandated by law to include all clinical trials being conducted in the United States or by any company that is based in the United States. So we have access to those data, and we have published an annual report. Now, this is our 8th year of publishing it, and we have been able to study what types of drugs are being studied and which ones are successful, how many are in all these different categories that might be anti-inflammatory or anti-tau or anti-amyloid. What does the expense look like? What effects are the biomarkers having, and what biomarkers are being used? How long are trials? How many patients are included in trials right now? I'll just give you an example. To populate the clinical trials going on at this moment, we need 50,000 patients. Well, it's very hard to recruit 50,000 patients, and it takes a long time, and that's why recruitment of patients is one of the slowest aspects of drug development, is because it takes a long time to recruit the patients. We need a national initiative to acquaint people with clinical trials, to help them understand their value, to help them understand that they actually get better health care in a clinical trial than they do without a clinical trial. And we particularly need to engage minority patients. Our clinical trials do not have adequate diversity, and yet we want to understand, do these drugs work in all people? And what does the safety profile look in all people? So we are behind in terms of diversifying our clinical trials and being able to answer those important questions.
Do we know if there is a difference in incidence of Alzheimer's depending on gender, for example, or ethnicity, or if any of that is impacting the incidence of the disease?
It's very important. For example, Alzheimer's disease is about twice as common in African Americans than it is in white Americans. It's about 1.5 times more common in Hispanic Americans than it is in non-Hispanic whites. It is about 1.7 times more common in women than it is in men. So all of those things, all of those aspects that you mentioned, being female, being Hispanic, being black, are all risk factors for Alzheimer's disease.
So the gender makes sense to me because women typically have lived longer than men, right? And the longer we live, the more likelihood that we're going to have the disease.
So that accounts for part of the discrepancy, but it doesn't look like it represents all of the discrepancy. It looks like women are biologically predisposed to Alzheimer's disease for other reasons as well. They have a different amyloid protein pattern in the brain.
Different than men.
Different than men. Sorry, different than men. Their neuropsychological patterns are different, which makes us detect them later in the disease. They tend to have better memory than men, and so they get further into the illness before memory is sufficiently compromised that we can detect the disease. So there's a lot of gender differences that we're just now beginning to understand. So
I'm trying to not say something about women having better memory than men because this will get me in trouble as well. But and why do you think, or why is there evidence that you have differences across ethnicity as well?
One is medical comorbidity. Diabetes, for example, is a risk factor for Alzheimer's disease, and diabetes is far more common in both Hispanics and African Americans than it is in whites. So at least part of the difference is the predisposing health circumstances that create Alzheimer's disease.
Are there other predisposing this gets back to the nature-nurture conversation, right? So and I know it's not exactly a defined number, but percentage of nature involved or genetics involved with the disease versus the nurture that's involved, because we can't really do anything about the genetics, right? So the nurture piece becomes very important.
Exactly right. And there's been wonderful work on risk factors for Alzheimer's disease. And it turns out that 30 to 40% of the risk is due to lifestyle factors. And those lifestyle factors would be low education, low activity levels, obesity, smoking, hypertension, and cardiovascular risk factors, lack of social engagement, depression, are all risk factors for Alzheimer's disease. And I think our greatest hope from a public health perspective is to address those more effectively than we have. Again, we need a nationwide brain health initiative that teaches people how to take better care of their brains.
So in the clinical trials, one of the things that you're pushing for is that we have a more diverse group of individuals that are going into clinical trials. One of the things that is, if you wouldn't mind explaining, you don't get access necessarily to the Alzheimer's patient. They don't volunteer for the study, right? It's their family members that will volunteer them, or how does that work?
It depends on how severely affected the patient is. We're studying mainly mild patients now, and so they can seek a clinical trial. Or it is also very common for their wife or husband to hear about a clinical trial in the news and say, doctor, I'm very interested in this. Is there a clinical trial that my wife would fit into? So that it's a combination of advertising for clinical trials, having clinicians be alert for the appropriate patients, and then some self-referrals to clinical trials.
Because the ethical concern is there as well, right? If someone is not of sound mind and yet they volunteer for a clinical trial.
Yes, we are concerned about that. Of course, we wouldn't want to impose a clinical trial on someone. So what we require in someone who is whose mental capacity is compromised is that they must assent to the trial, and the caregiver must consent to the trial. So the caregiver says, I'm speaking for my wife, and I believe that this is consistent with her philosophy that she would want to participate in this clinical trial. And then we say to the wife, the clinical trial would involve you coming to see your doctor and having scans. Are you willing to do this? And then they say yes or no, and so that represents the assent part of it. It's imperfect, but I think it is ethical, and I think it is important.
You mentioned earlier that women are more likely to have Alzheimer's than men. Are there hormonal differences? Do we know any either causal or correlational aspects of hormones related to Alzheimer's?
Yes, it's been an area of intense study, Mark, where the menopause and the acute deprivation of the brain of estrogen does appear to be destructive. And if the data are still being shaped, still evolving, but appears that if a woman starts hormonal replacement therapy at the time of or soon after menopause, their risk for dementia will be diminished. If they wait several years and then decide that they are going to go on to hormonal replacement, their risk for dementia may actually be increased. So how long is that interval before we are switching from decreased risk to increased risk? That's still a matter of study. Is it the estrogen or is it the progesterone? Which hormone is most important? These are the questions that are understudied now. So we have a long way to go, but it does appear that the menopausal event in women is a part of their increased risk for the disease.
So at least right now, the science would suggest that if the earlier hormonal replacement therapy after menopause, the better.
That's correct.
And so in a way, these the hormones are neuroprotective, or well, it appears that they are.
I would say that's true. That we don't know that they're directly neuroprotective, or maybe they're affecting some predecessor event that would lead to the cell death. All of that is being worked out now. Do they have an effect on amyloid? They might. Do they have an effect on inflammation? They might. So those are the things that are being worked out.
So while we're talking about this, what are some practical areas that things that people can do, supplements, et cetera, not necessarily pharmaceuticals, that they could do that would either directly stave off or decrease Alzheimer's, the incidence of Alzheimer's? What would your suggestions be?
The most important thing that we've learned is that exercise has the most reproducible effect. And people should try to get to 150 minutes per week. So roughly a half hour a day, or on the order of a half hour a day, will produce a meaningful slowing of the progression of memory loss, for example.
And And when we're talking about 30 minutes a day or 150 hours a week.
150 minutes a week. Yes,
sorry.
right.
Yeah. Oh, that's overboard. So yeah, 150 minutes a week. Cardio, exercise, weight training, what would you say?
Yes, all of that, rapid walking, something that's demanding, something that is demanding enough to get your heart rate up at least a little. We know that people aren't going to go out to a track meet and try to do the hurdles, right? But they will benefit most if there's enough demand to get their heart rate up. One of the things that's very, very important to me is that they've done work on the people who carry a risk gene for Alzheimer's disease and those who don't, and those who carry the risk gene benefit as much or more than those who do not. So in that case, the gene is not fate. Mm-hmm. It's still manipulable, even though it's exerting its risk. You're also able to deny the risk through exercise.
So exercise seems to be able to have a gene regulation aspect to it.
I don't know the mechanism. It might be gene regulation, or we know that exercise produces BDNF, a growth factor, mm-hmm. and maybe it's exerted through that and is just as active or more so in the risk gene carriers. So I don't know the exact mechanism for that. But you asked more broadly about, for example, other things that mm-hmm. people could do. Healthy diet is very important. And a good way to remember this is your food should be colorful. And so if you eat colorful vegetables, those are very high in antioxidants, and they are most likely to protect the brain. Red meat has the greatest destructive effect on brain health, and fish and poultry less so. So a diet that is high in vegetables, particularly colorful vegetables, colorful fruits, and low in red meat will be the best for brain health.
So you mentioned about the genetics that related to Alzheimer's, because there's genetic testing now, and people might see that they have, one or two of the gene types that are going to be more likely to have the disease. Can you talk a little bit about that, what the genes are, and also it's great to hear that exercise can have a positive effect.
Yes, so there's one very powerful risk gene called ApoE, mm-hmm. And it is there are 3 types of this gene, and if one gets the one called ApoE4, then that person is at increased risk for Alzheimer's disease. They're more likely to get it, and they're more likely to get it earlier in life, like around 65 rather than around 75. If they happen to get 2 copies of this gene, one from their mom and one from their dad, then their risk for Alzheimer's disease is very high, around 80 or 90%. So most of those people, fortunately this is pretty rare, but most of those people will get Alzheimer's disease. So these are risk genes, and it's important to remember that a person can have a risk gene and not get the disease. And that's why the exercise might be very important in this circumstance. But they are more likely to get the disease if they have a risk gene. But it's not like fate, where if you get the gene, you're going to get the disease. There are such diseases. But this gene is not like that. It makes it more likely that one will accumulate amyloid in the brain, and therefore more likely that one will get Alzheimer's disease.
There's a show on Netflix, Chris Helmsworth. Do you know this show? He did the genetic testing, found out that in fact he has 2 copies, and essentially is documenting his life to look into ways to deal with Alzheimer's. He exercises on a regular basis, healthy diet, and so forth. And it's really fascinating. I think one of the things that's done is it's brought to the masses this idea of the genetic testing for it. You had talked just a little while ago about blood testing for it, which I think would be phenomenal. if we're able to do that.
Yes. So those blood tests are already available. They're still not widely used because doctors are still very unfamiliar with them, and they're not reimbursed by Medicare yet. So we have the tests, and people can ask for them and pay for them. We don't recommend it yet unless there's someone with expertise available to interpret it. So at this point, it is, and I think should continue to be, pursued in research centers where people can get the education associated with those tests that they need. But we're on the verge of having this come into clinical practice. We're right where maybe the PSA was 20 years ago, when people were beginning to understand how to interpret a prostate test, or even longer a diabetes test. This is the kind of information that we're going to get from these new Alzheimer's blood tests.
How about gut health? What do we know about gut health related to Alzheimer's?
The information on the microbiome is just becoming so influential in terms of our thinking. They say it's a movement too hard to resist. And the microbiome is changed in Alzheimer's disease, and there has been at least one drug in clinical trials that changes the microbiome back towards normal. Now, that trial was not appropriately completed, and so we didn't get the information that we needed from that trial. But I think that was a pioneering drug, and we're likely to see more drugs where we explore the benefit of changing the microbiome back towards a more normal composition, and therefore the microbiome's connection with the brain restored to a more normal interaction.
You know, Jeff, it's really interesting. The different drugs that you're talking about, the environmental and nurture aspects that contribute to it, things that decrease amyloid but don't stop the progression, on and on. It just really goes to say what a multifaceted disease this is. There's so many different aspects to it.
That couldn't be more true. We know that there are these environmental aspects, there are genetic aspects, there are gut aspects to it. There are environmental exposure aspects that are being increasingly investigated. So it's not surprising that it's been so difficult to find an intervention that is working, and it's going to continue to be hard work to find the next class of drugs. But we have the tools to do it. Finally, we have, and that toolbox is tremendously important in terms of advancing our progress.
So your biggest hope over the next 5 years, let's say, what are you most excited about as far as Alzheimer's is concerned?
I want my patients to have realistic hope that they can preserve their cognitive life to the end of their physical life.
Yeah, we would all like that, right? I've got a couple questions. I hope you don't mind. Very interested to know, what is your North Star? What is it that drives you to do this work?
Do good. I feel like doing science is doing the right thing for people I want to help, which is all older people, all aging people, which is all of us. And I think I have the sense that I am trying to orient towards what is the right thing to do, and that is a good thing to do.
Yeah, I love it's so obvious that you're passionate about this, and I think about the story that you told about the young man from Wyoming growing up to do the things that you're doing and making the contributions that you're making. I'd like to know a few moments of joy that you've had in your life.
They are with my wife, for sure, so shared moments are so important. Last year we were in Africa, in the plains of the Serengeti, and there is just nothing that matches being in the Serengeti and you can look out the window of the vehicle 20 feet away, and there's a lioness and her cubs, and there you are with your wife, and the surroundings are gorgeous, and you're reunited with nature in a truly deep way. And that would be a moment of joy.
Can I ask you before you go on, what are a few more things that you saw that just really captured you? Like the sparkle in your eye right now as you talk about it's fantastic.
Well, seeing a leopard move along the edge of a creek bed, and then eventually find a little cave where he could withdraw into the cave was remarkable. Getting too close to an elephant calf and seeing the cow turn towards the vehicle and ready to protect her calf was a pretty impressive moment. So there were just so many things. We were sitting on the porch in the back of our tent when a lion walked through below the porch. So those are remarkable moments.
How did you feel in that moment?
Uncertain.
That's fantastic. Other moments of joy.
Other moments, we love history, and so let's take the Vienna Opera House as just a wonderful moment in time where you're surrounded by wonderful architecture. The acoustic environment is filled with these powerful voices. You're there with someone you love. What could be better than that?
Yeah, that's fantastic. I love that. I love it. Favorite restaurants in Las Vegas?
I love local restaurant. Tuscany Grill is the one we'd go to right down the street. Love to do that. If I'm going upscale, I love the Picasso, and going and of course, when the real Picassos were there, that was a more meaningful experience. But even now, that's still a really, really great restaurant. So I would choose my favorite restaurant based on the experience I wanted to have.
Mm-hmm. Mm-hmm. And Saturday mornings, 10 o'clock Saturday morning, where do we
10
find
o'clock
you?
Saturday morning, I've just finished my exercise. I am sitting at my desk trying to get a little work done before my wife and I go out and do something for the afternoon.
So you exercise, you practice what you preach.
Yes, I practice what I preach.
So Dr. Jeffrey Cummings, there is a old commercial about beer, and the guy says, I'm the most interesting man in the world. I think that he's been upstaged by you. So thank you so much for being here.
Thank you. Thank you for a wonderful interview.
Pleasure.